For more than a decade, Nigeria has been the most dangerous place on earth to give birth. Nigerian women are dying from pregnancy or childbirth complications. Almost a third of maternal mortality deaths happen in the country. According to the World Health Organization, 75,000 women in Nigeria died from pregnancy-related complications in 2023 alone. That's one death every 7 minutes, most from preventable complications. The leading killer is postpartum hemorrhage, severe bleeding after birth. That can turn joy into tragedy in minutes. DW's Olisa Chukwumah has more in this report.
A medical checkup that could be life-saving for mother-to-be and baby. Women at this community health center in Lagos are here for scheduled antenatal care. Nurses monitor their health and that of the developing new life, providing medication, support, and education.
I'm 6 months gone. It's important to go to this program today because as a pregnant woman, I need their care, their attention, their support.
It's important because there might be complications and I don't know myself until I've been checked. So if I'm not checked, I won't know if the baby is fine, if I am fine. So that's the reason why I came.
It's organized by Maternal and Reproductive Health Collective, an NGO which reaches out to women from vulnerable communities aimed at avoiding complications ahead, especially during childbirth.
Every day in Nigeria, dozens of women die from pregnancy-related complications in tragedies that are preventable. It is why early interventions are needed, especially within local communities.
Lack of money often stops pregnant women from seeking medical care, along with deep cultural beliefs and a lack of trust in the healthcare system. But this can often have fatal consequences. Hadiza Bakare is 6 months pregnant with her 4th child. Like many women, she has experienced the loss of a close friend.
During childbirth, during the delivery process, she couldn't make it. But because before they could transfer her to a general hospital, she couldn't make it. So both the baby and the mother died in the process.
Already 4 months in, Aishat Okunloye is hoping to avoid the complications she experienced, giving birth to her 1st child.
Through the 3 days I go through nego, it's very stressful. I'm crying. Even my mom, everybody was worried that I should not die and the baby should not die. I'm just scared though. To be sincere, I'm scared because I don't want any trouble and any complication. I just want my baby to be fine and me too, I should be fine through my delivery.
With one death every 7 minutes from pregnancy complications, Nigeria is the country with the highest number of maternal deaths. Frontline workers want to save lives by identifying and registering pregnant women within at-risk communities.
Our aim is to ensure that no woman dies from giving birth, because childbirth is not a death sentence. Pregnant women need to be supported. Pregnant women need to go to the hospital when they're pregnant. They need to attend their appointments. They need to deliver where there is skilled care.
Health workers want to be the first point of medical contact for pregnant women and limit avoidable risks.
If they register early, we monitor them. So monitoring too, very, very important. So they register early, we monitor them, and if there's any complication, we refer early, and they don't die. Because where we are referring to GH, General Hospital, in which there are doctors, experts that will take care of them. They won't die because we refer them earlier.
Last year, Nigeria's government launched a federal initiative to stop women dying during childbirth. But it is efforts like these on the ground that can have a life-saving impact for pregnant women and their babies.
Right, so postpartum hemorrhage, or PPH, is the leading cause of maternal death globally, led by Nigeria. So what exactly is PPH and how do you prevent it? I put that question to Hadiza Galadanchi. She's a professor of obstetrics and gynecology and the director of the Africa Center of Excellence for Population Health and Policy at Bayero University in Kano, Nigeria.
All right, so just as you've said, we have like about 14 million women actually having postpartum hemorrhage every year. Out of this 14 million, about 70,000 of them would die. A majority of them are in the low middle income countries, including Nigeria. And in fact, Nigeria is one of the countries that contributes the highest deaths of postpartum hemorrhage. Now, researchers, all over the world, including myself, now, sat down and said, why is it that women are still dying, despite we have everything to prevent them from dying from postpartum hemorrhage? And we identified 3 reasons. One is that we really don't make the diagnosis on time. We delay in making the diagnosis because the diagnosis is based on an estimate of blood loss after delivery. And this estimate of blood loss, we always do it subjectively and virtually just looking at the floor, looking at, the clothing, looking at, the patient. We make an estimate of the amount of blood she's lost. No objective assessment. And that's the first delay, because unless you make that diagnosis, unless you objectively assess blood loss, you will not start treatment. And the second delay we found was that we have like 5 different interventions that you can use to stop the bleeding, but then we give one and we wait for hours waiting to see whether that one is working before we get to the next one. So we also realize that that's also a lot of delay. And then the third delay is that when we are not able to address, the bleeding with these interventions, we waste so much time before we get to the next level. And the next level is take her to the theater, do surgery, and prevent the bleeding from occurring. So these 3 interventions, these 3 delays were what we realized were the major causes of death arising from postpartum hemorrhage. And we went ahead and decided to address the 3 delays. The first one, we now said, you have to have an objective assessment. So you have to know exactly the amount of blood this woman has lost. And for this, we used a drip. You use a drip and you can see exactly the amount of blood loss that the woman has. The second thing we said, why don't you give all the interventions at the same time? Which means you give the massage, you give the oxytocin, you give the tranexamic acid, you give the IV fluids, all at the same time within 10 to 15 minutes. Don't waste time waiting for one to work. Give them as a bundle. And then the third aspect was that if for 15 minutes you've given the bundle and the woman is still bleeding, don't waste time. Get to escalation, examination, escalation, and that's the E. So that's why we got the E for early detection, MOTIVE, motive for the bundle, and the last E for examination and escalation. And that is our emotive intervention.
Right. That's interesting. I was going to ask you more about the emotive trial, which you've been researching as a solution, and your study found a 60% drop in severe bleeding with, as you say, a simple drape plus a treatment bundle. On the one hand, it's a trial that was successful, which is great. But how do you, project this on a larger national and even international scale?
Excellent. So when we did this research, and it was a research across 5 countries, all right, Nigeria, Kenya, Tanzania, South Africa, Pakistan. And when Nigeria, actually we had half of the data coming from Nigeria. And by the time we got the result, which as you said is 60% reduction. So where we didn't use intervention and where we used the intervention, we found out 60% reduction in severe PPH and therefore, leading to maternal death. Immediately we made that pronunciation of the results. We now published in a high impact journal, which is the New England Journal of Medicine. And immediately WHO took it up and now, updated their recommendation. So the global recommendation came out just 6 months. I say 6 months after our publication, 6 months after WHO had updated their guideline now to include 2 recommendations. One, every single woman should have an objective assessment of blood loss after delivery. 2, if you have postpartum hemorrhage, which is either 500 mils of blood loss or 300 mils plus, an abnormal sign, trigger the bundle. And the bundle is MOTIVE. All right. So with that recommendation, countries now had a global, document for them to now go back, to start implementation in their various countries. So, for example, in Nigeria, we realized that we didn't even have a PPH guideline when the WHO new recommendation came out. So we now said we should have our own national guideline using the recommendation. And we now have a guideline that uses these two recommendations that were advocated by WHO. And then the next thing is implementation at the national level.
Right. I mean, that's always where the challenge comes sometimes, isn't it? When the implementation, if it goes smoothly, then the problem is solved to a large extent. But if not, then we have a problem. But you've definitely played a key role in all of this so far. The first female obstetrician in Kano, Nigeria. That deserves a round of applause. You're also a mentor to thousands of people. How have gender dynamics influenced your career and the broader fight against maternal mortality?
Actually, it's been very positive. As an obstetrician, a female obstetrician, you can't have anything better for you to really understand what is happening. I always tell my male colleagues that, you can never imagine what labor is because you're a male, not a female. So really, being a female obstetrician has really given me an opportunity to really be an advocate for women's health. And being a female has not really, reduced my ability or given me any challenge. In fact, it's even more positive than negative. Yes, I know in a lot of places I'll probably be the only female there, especially, things are changing. When I joined obstetrics, gynecology and obstetrics, there were very few female obstetricians, even in Nigeria. But now there's so many of them. In fact, in Kano now, the obstetricians are becoming, they're going to be more than the female obstetricians are going to be more than the male obstetricians.
Well, that's great.
And especially where I come from, women, a lot of women would prefer female obstetricians as compared to the male obstetricians. So really, we're now having a lot of our young girls are getting into, the specialty of obstetrics and gynecology. And once we have a good number, I think advocacy will really be something. There will be a change because female obstetricians are great advocates. Because they know it, they have experience it, they understand it far better than the male obstetricians.
Right. Look, you've said it all. I am male and cannot understand the challenges that women go through, but I have learned a lot from what you have told me today, and I really appreciate your time. Hadiza Galadanchi, an advocate for maternal health in Nigeria. Thank you very much for your time.
Thank you very much.